Okay, we're here on the third episode for Let's Fix the NHS, and we're here with an amazing local GP for actually my local GP and what was my mum's general practice in Stoke-on-Trent in a little place called Kisgrove. And Dr Zainab Hussain is TikToker and Facebook GP and Instagram star with many medical and doctor related posts over the last couple of years. So rather than people at the other end of the health service like David Haslam and Sanjeev Nayak, we wanted to talk to someone who's there every day at the coalface, seeing patients, dealing with life as a general practitioner and as a busy mum. And let's talk about how things are in the NHS for you, Dr. Hussain. Shall I call you Dr. Hussain or Zainab? What would you prefer?
Yeah, you can call me Zainab. Thank you so much for inviting me, by the way.
Well, I mean, quite the opposite. I want to thank you for agreeing to this because, you know, if there was 50 or 100 videos out there already that people could see and look at for, you know, what is this I'm getting myself into, then, you know, it's a little easier. But the fact that you're early in this schedule, I really do appreciate. And yeah, I mean, perhaps we just start by, you know, your background and I think right from the earliest part, what made you decide you wanted to be a GP?
Yeah, thank you so much, Steve, for that lovely introduction. Basically, I was born and bred in Cardiff, so South Wales, and I lived there till I was 19 and went to Brighton and Sussex Medical School. Haven't thought about why I wanted to become a doctor in the first place. I didn't want to be a GP in the first place. I just wanted to be a doctor and help people in hospital. That was the main thing for me. I guess the glamour of casualty and Holby City was all there in my mind. Becoming a doctor was a dream of mine since I was about 7 or 8. And visiting the GP myself, having been to hospital with broken bones, it just made me want to help people even more. That, you know, I felt like, wow, they're amazing. Maybe I could be someone like that in the future. And obviously in those days, 2004 is when I started medical school. It wasn't that easy to get into medical school. It's even harder now. But with the support and help of my college, of my mum and dad, they made it all very possible.
What did your parents do?
So my mum and dad, my dad owned a corner shop at the time. He's now a taxi driver and he still works as a taxi driver. My mum is a housewife and does a bit of beauty work on the side. And that's it. But they're amazing people. And I know that if they got the opportunity to have an education, they would have done even more than I have, which is why I strive to be the best I can be in this field.
Oh, that's amazing. And do you speak to them regularly? Are you in contact?
Oh, yeah, every day. I think they sometimes get annoyed with me, but yeah.
Well, and what do you think they think of what you're doing?
They are very proud of me, but it makes me, you know when people say what it motivates you, it motivates me that they are proud of me, and I want to do even more and show them that their hard work hasn't gone to waste. You know, they worked so hard to raise us, to send us to university, to get us what we needed to do the things that we're doing now. And so it just, they are my motivation, and they're proud of me, but I'm proud of them for giving me that confidence and being the best parents. And I just hope I can be that for my kids.
We'll come on to your kids in a little while, if it's all right, if it's okay. But do you have siblings? Do you?
Yeah, so I'm the oldest. So, you know, the older sibling syndrome. I think I was like always lecturing the younger ones. I've got a younger sister and then a brother and then another younger sister. So it's 4 of us.
But are you the only one in the medical field, or?
No. So my brother decided he wanted to go into medicine after I had got in. And now he's a GP, a partner in South Wales. And then
Okay.
my sister, who's younger than me, went into pharmacy, and my baby sister, she obviously not a baby now, but she's in was in podiatry, but now she works as a in mental health.
That's incredible. So, wow. I
Yeah,
mean, giving so much to society, it's fantastic. So I'm sure your parents are very proud, and if they watch this, hopefully they learn a little bit more about what you're doing. I'm sure you tell them all the time, but
yeah.
and so go back to Sussex and Brighton. How did you get there? What was the path?
Yeah. So when I first applied, it was a new medical school. There was already just 1 year in. I was the second year going into Brighton. Because it was one of the new medical schools, I just thought that everyone there is going to be new. They're going to want to make it a success, and I want to be part of that success. So applying there was through UCAS form, and we had to do a personal statement, write all our grades down. They invited me for interview, and I was actually interviewed, interestingly, by a lecturer from Cardiff. So he'd moved to Brighton to be an anatomy demonstrator. So it was him and a fellow GP that were interviewing me, and that was interesting because when I was working as part time in House of Fraser, and he knew that House of Fraser and what it was like, and he said, "Oh, the food hall's lovely. Like, what do you think of that?" And I said, "Well, we don't use that. We have a staff room, and it's not as nice." And we just had a bit of joking kind of conversation as well as the interview. So I think that really helped.
Handy for sure, because I'm sure it
Yeah.
was competitive. But
Oh yeah.
and how was life in? Was it? Were you living in Brighton, or where were you?
Yeah. So I lived in Brighton for the whole 6 years because the medical school's 5 years, but I took a year out in between third and fourth year. I did a degree in pharmacology in Brighton. So essentially I was there for 6 years. Absolutely loved it. It was a brilliant place to be a student, and I made lots of friends and learned a lot about myself. I grew up quite a lot because I was away from home for the first time, learning about rent, money, how to handle money, being responsible, getting to lectures on time, just growing up, yeah, and meeting lovely people.
So they say kind of learning the piano is a little bit like it's a nightmare. You struggle. You think I'm never going to be able to do this, and then all of a
Yeah.
sudden you kind of find your groove. Was medicine a little bit like that? Was it something where um, it's daunting, I guess, for someone new in? Was it something where you always were confident, or was it something that you struggle with at any point in those studies?
I would say the medicine is not a hard subject. It's more about the volume. When I started medical school, I don't think I was thinking that, this is very easy. It was difficult. There were a lot of concepts and a lot of pharmacology, biochemistry that sometimes it's hard to get around all of them. You can't be good at everything. But what I found my strength in was the fact that I was passionate. And if they related back to a patient situation, it made it easier to remember why that pathophysiology was happening and why we were doing certain treatments. So I think that made it a little bit easier. And plus, I love people and their stories. So for me, that passion was just even more kind of fulfilled, and it made it easier for me to remember stuff.
It's interesting when things are vocational, when there's a story behind it, people can relate a lot more and retain a lot more. I mean, when you
Yeah,
think of teaching methods, then I mean, it's not
yeah,
that long ago, but it is really before YouTube and before a lot of Khan Academy, and there's so many e-learning
yeah,
tools that are out there now.
yeah,
When you look at people who are learning, because I know you've done some work, in the career arena.
yeah.
When you look at people who are going into medicine now or learning now, do you think it's easier or harder now as opposed to back then?
I mean, back then, I mean, the medical school was new at the time, so they were kind of going through trial and error of what works and what doesn't work. In the medical school, we had seminars, we had lectures, we had dissection of the human body, we had different methods of teaching, we had on the bedside teaching with patients, GP placements, hospital placements, and I think it really catered for all types of learning. The one thing that has changed, you're right, it's gone very much electronic. When I was at med school, we did have a student dashboard, so we did have internet, but not in our homes. We had to go to the library to access the work. But it has moved on. But I think it is easier now to access knowledge. Like in those days, books and things were you had to buy the books, but now there's a lot on the Kindle. There's lots online. So that's easier. There's a lot more knowledge online, like Wikipedia, and that you can gain, and studies and things that you look in PubMed, for example. So there was less of that kind of access when I was doing medicine.
There's also a lot
But
more
I
to
mean,
distract us now, isn't there? So it's
oh my
kind of
goodness, yeah. The generation now is definitely more distracted. There's a lot more people on TikTok now who are medics than, I mean, I didn't even know of TikTok until a couple of years ago. So yeah, there's a lot of information on there to that
so
people take.
so fast forward. So if you so when you graduated,
Yeah.
what happened then? What was your first role?
So my first role was in renal medicine and kidney transplant. That was my first ever job in Leicester. Amazing, amazing job, but it was scary at the same time because I'd never even worked in a transplant unit before. I'd never done a placement at medical school, and the medications that we were prescribing, like immunosuppressants, like tacrolimus, were all very kind of toxic medications that we were prescribing, but good for the patient. But I was really scared initially. But one thing I did learn was that getting the nurses on your side was an amazing thing. The nurses have been there for such a long time, and they
Right.
used to help us out a lot. Yeah.
And I mean, so the placement,
Yeah.
you could have gone anywhere. Um,
Yeah. I
did you have
actually
choice, or
applied.
what was how did that process work?
So when I applied, we did have to rank our jobs. We had the choice to do that. We weren't going to be randomly placed. If we applied and our application was good, then yeah, you got your first choice. I managed to get my first choice in Leicester, and yeah, and I mean, in terms of jobs, it wasn't that I just wanted to choose. I chose cardiology as part of the first year, but then I got this on the side as well. So yeah, it was a little bit easier this time around. I can see F1s going all over the country and not knowing where they're going to be, but it wasn't like that for me.
For people who don't know what's an F1,
So an F1 is a first year junior doctor, and they call them resident doctors now, from what
right?
I understand.
So how long were you there in Leicester, and what was what did you find most interesting about that sort of
Yeah.
experience of from medical school to essentially a life-saving treatment and supporting the consultants and what did that role involve?
Yeah, interestingly, in your fifth year, when we were in fifth year, we did a lot of placements in the hospital. So we were following the people that we were going to be, so the F1 doctors around the hospital, pretty much for a good few weeks. And before I started the job, we had a shadow induction week where we would be with the consultants and with the F1 doctors, almost kind of helping us prepare ourselves for where we need to be for certain times of the day, where the handover happens, where the patients are, what wards we're covering. So it wasn't as scary because I kind of knew what I was doing. But what I found interesting, and no one tells you this until you're on the job, unless you know beforehand, and maybe people are a bit much cleverer than I am nowadays. But when I first started, I was on an on-call shift and had this blood test result back, and the kidney function was way off. Like the urea was like 200, it was just crazy, and the creatinine was like 1200 or something like that. I quickly bleeped the registrar there and then, and she goes to me, Zainab, have you seen the previous result? So I clicked on previous, and it was even worse because the patient had had a bit of dialysis, and that was the next. So it's really important to look at previous results. So this is one of the things that I kind of learned on the job. The other thing I learned was that you can hand over, because when I was doing my on call, I was given a list of jobs to do, and I thought I had to finish all those jobs, whereas actually at 9 o'clock, I had to go to the handover room, give the bleep over, hand over the rest of the jobs to the fresh face coming in. But I stayed until about 10, half 10, trying to finish everything. And this so yeah, the senior house officer was waiting for me, and he said that you can hand over. It's really important that we don't burn out in hospital, because the danger is that you end up making mistakes, or you end up getting exhaustion and things like that. So it's, for me, knowing that I can hand over was important. That I didn't have to finish everything off.
But that's interesting. So going back to the discussion with Sir David Haslam, one of the things, I mean, and he talked about it in the context of general practice, but the continuity of care aspect, and I think I mentioned to him that the thing that amazes me is the flow of information within the medical environment, and this concept that it really is, you could have 10 doctors in a period, or 5 if you're there in hospital for a couple of weeks. And, because people are on holiday, people are not working, people finish their shift, so when you look at that aspect of care, whether it's in general practice or whether it's in a hospital environment, how do you deal with that? Meaning you're coming in to somebody you're not seeing, you've got to get up to speed very, very quickly. Yes, there might be a handover, but sometimes there's gaps in that handover because speed is the essence. There is clearly, notes and records of all different types, but what's difficult about that, and how long does it take to get up to speed?
Yeah, it doesn't take long. I suppose the documentation is very important. So every morning in the hospital, you have a handover. You also have ward rounds as well. So you, with the consultant, go round to each patient. There may be new patients that have come in overnight, or there may be some patients who have been there for a while. So, but it's all about making sure that you write a job list, and you write a problem list for each patient, so you're aware of the issues that have happened. I'll just tell you one really quick story. There was a patient, once I came onto the ward, it was just me and the consultant and the team, and he hadn't arrived yet. I used to arrive early to try and get up to speed. So when the ward round happened, I knew all the patients and almost kind of helped him out. And this one patient had a GCS, which is Glasgow Coma Scale, of 8 on my ward. And this is like an unconscious person. And she was someone who had a history of alcohol dependence, had a head injury, and was brought in. But for some reason, she wasn't intubated. She was just told that she was fit for the ward. I couldn't believe it. Anyways, waited for the consult. I quickly rang the anaesthetist. Also waiting for my consultant to come on the ward, but I couldn't delay much because he was going to be another half an hour. And they took her straight into to be intubated and CT'd and things. And she did have a huge hemorrhage in her brain, and was taken to Walton Centre. This was when I was in Bangor, and these kind of, when you go on the ward and that kind of thing happens, all the other patients just go to the sideline. You're just dealing with that one patient
Right.
in that moment. It is. Do you know what? It is difficult to be up to speed, but not that difficult if you're quite organised and you have a job plan. You know who's come in, what they've come in with, what the plan is from the notes. You just do it. It's just part of your day, and you just get on with it.
But it's interesting. So quite a few years ago, I had a share in a career consultancy, and we did career
Yeah.
advice and talent management, and it's really interesting how some people are just not suited for certain types of role. So take a lawyer who is not very good at verbal reasoning and not organized. People can overcome their natural limitations or work towards their natural strengths. But sometimes when you do that, you really struggle, and people get depressed. People hate their work environment. So do you think your natural ability lends itself to medicine, your natural organization.
Yeah, I think you have to be a people person. You have to have detective skills. You have to be interested in everything. One thing about general practice is that communication is the most important. I think even more than knowledge in some ways. If you can, your knowledge is there. Knowledge comes and goes in some ways. You can revise things, you can re-revise things. But if you haven't got the basic communication skills to get that data from the patient, the history, then you're not going to do very well as a GP or even as a doctor. And if your interpersonal skills with the patient is not there, how are you going to expect that patient to tell you what's going on and then help you in their diagnosis and treatment and management? I just think you're absolutely right. I do think my personality suits medicine. I don't think I could have been anything else. Whether I don't know. I always thought about being a police officer at some point. I thought maybe when I retire, I'll join the police force as a special constable. But maybe I'm just too naive. I think everybody's lovely, but obviously the world isn't like that. So yeah, it's your personality. It makes a big difference. Many patients will come and see me and say a doctor's been cold with them, or they haven't. They felt like they haven't been listened to. But I actually sometimes don't know if that's what's happened, because to be a doctor and to do that work day in, day out, you've got to have passion. Like, how can you survive years of this job if you don't love people?
But I think some people are genuinely more in their head and with interpersonal skills that are not ideal. In fact, the very practice you're part of, which was where I went to as a child, it was
Yeah.
it was elsewhere. It wasn't in the medical centre where it is right now, but it was in Kidsgrove itself in Market Street, and I do
Oh,
remember the quite scary. I won't mention the names, but it, it bedside manner. I don't think was a term
yeah.
invented for these GPs back in the day, but that would be in the
Yeah.
70s, in the mid 70s. But um,
There's almost like an ego thing. I don't know, in the back in the day, like if you look at Carry On films and various other kind of comedies that were created to take mockery out of like what doctors are like on the ward round and things. But these are actually true things that have happened. When you watch Scrubs, that's quite an accurate version of how sometimes consultants can be a bit, flippant and say rude things to the juniors and say, oh, do this and do that and be a bit mean. But in my opinion, I think we should, the NHS is a caring profession, and we should all be caring to our colleagues and kind to our colleagues, as well as be kind to patients, because health and mental health is so important. And if you go to a doctor and you feel like you're not being listened to, how much are you going to tell them?
right.
And are you actually going to go to them in the first place? Yeah.
And it's interesting these days with AI, with ChatGPT,
Oh, indeed.
people are using ChatGPT as almost like a therapist, and to give their problems to. And we know that the new NHS plan is soon to be announced, and pretty sure there's going to be a great deal to do with AI in that
Yeah.
plan. But it is interesting, just when you look at the constraints time wise and resource wise, which we'll come to in a moment. I want to just finish the sort of career path, if you don't
Mm.
mind, first. But
Yeah.
sort of tracking those changes over the years is very interesting. But go back to, say, renal medicine, and
Yeah.
what came next, and
So,
why the change.
yeah. So when I finished renal transplant, I actually transferred back to Cardiff for family reasons, and did trauma and orthopedics there. So I was a spinal F1 doctor, so spinal resident doctor, and then I did general medicine, diabetes. So that was what I did after that. And then I did my F2, which is my second year as a junior doctor in Bangor. So I did general practice, and that was the time around which I applied for general practice as well, at the beginning of my second year, and also did psychiatry and general medicine.
Wow, so that's quite a a varied
Yeah.
a varied training from internal medicine, from spinal. I can imagine
Yeah.
that's a precision instrument, isn't it? The spine,
Absolutely.
and it's mind
Yeah.
blowing what the surgeons can do. It really
Yeah.
is.
I had a really good team, and my consultant was Mr. Ahuja, who was there. And I do medical illustrations as well, so I did a big poster for him, like a present, to show him what I'd learned over the 4 months. And he still has it to this day. And actually, 2020, he rang me 10 years later and asked if I would be an illustrator for his chapter that he was going to be publishing in a book about TB and the spine. So these kind of contacts that I've had, they've remembered me and what I can do, and then called me afterwards. So opportunities have arisen from that change. I was meant to stay in Leicester for a year, but I didn't, and maybe that was the reason that I moved to Cardiff.
So you moved back to Cardiff. You were in Bangor. How
Yeah.
did you get to Stoke-on-Trent? What happened there? And was there anything in between that we've missed?
Yeah, so I started GP training straight after the second year being in Bangor, and my first year was in Liverpool. And that's because I got married at the end of my second year of being a doctor, and then went to live in Liverpool because he was doing heart and lung surgery there. And so we lived there for a year. I did a lot of GP actually in my first year as a general practice trainee. I did GP plus palliative care in the first 6 months,
Okay.
and then I did 6 months of GP. And then in that year, my husband found out that he was moving to the Midlands, and we thought, let's move to Stoke because that's kind of close to Birmingham or Manchester, wherever he gets the job, we'll be there. So we moved to Stoke, but I stayed in the deanery of Mersey. So I moved to Crewe. So I did the rest of my hospital placements in Crewe
In Leighton.
following that. Yeah, so I was living in Stoke, but travelling to Leighton every day.
Okay. Leighton's another discussion. I mean, it's a constant. My family basically are between the Royal Stoke and Leighton
Oh, yeah.
Hospital, but we've always kind of tended to be at the Royal Stoke. Although other members of the family and friends have
Yeah.
been to Leighton, and it's geographically and physically, it's a difficult hospital. I just think in terms of
Oh,
how
yeah.
it's evolved. I understand there's quite a bit of construction work going on now, but
Oh, yeah.
in there's a lot of question marks over aspects of care at Leighton, including stroke. I know that their stroke capability is pretty limited, and when Mum was at the Royal Stoke after her stroke, I did hear a lot of cases coming in from Leighton because they just didn't have the capacity for them there. Yeah, very
Right.
interesting.
Wow.
Yeah.
Yeah.
So, but your experience there was positive, was it?
Yeah, I did pediatrics there, and
Hmm.
then I also did obs and gynae and A&E. But then my last kind of placement in that Mersey deanery before I had my second child was in Knutsford. So I worked in GP for a year in Knutsford. That was lovely as well. I mean, my trainer was, and I think it does make a big difference who your trainer is. He was fantastic, similar age to me, similar kind of life kind of situation to me, and that made a big difference as well.
So Knutsford, I also lived in Knutsford quite a few years ago. Although I've been in
Really?
London
Wow.
for 25 plus years, but before that I was in Knutsford, and I
Do you
adored
know
Knutsford.
Toft Road?
Yeah, yeah,
Toft
yeah.
Road. Yeah, so that was the practice I was working in for a year.
Okay, so
Yeah.
my GP back then was the main road, the main
Was it
London road,
Manchester Road?
Manchester Road maybe,
Yeah. Yeah.
and but it's a long time ago, a very long
Yeah.
time ago. Okay, so Knutsford, and then ultimately Stoke,
Yeah.
and and just the sort of decision to be in general practice. And
Yeah.
this is for me, it's a fascinating discussion, getting into some of the detail of your background, because mental health, spine, renal, what have I missed there? What
Just
else?
general medicine.
General.
General
Yeah, you
medicine,
mentioned a couple of other
pediatrics.
things. Pediatrics, yes. So
Yeah.
that is when people go into a regular GP appointment, they don't
Yeah.
necessarily realize that someone has been through all of the forms of medicine that you've been through.
Yeah, and every GP is different. So you might find a GP who's done another specialty for a long time and then decided to become a GP as well. So, and everybody's placement's different. Not every F1 program is the same. So yeah, every doctor has a different background, different strengths, different kind of limitations to their knowledge. But the GP training scheme is built in such a way that they try and standardize everything, and the examinations are all standardized and the same for everyone. So that's how they kind of get rid of the kind of differences between each candidate.
And going back to that sort of decision
Yeah,
to get into general medicine, or to sort of focus on general medicine, where did
yeah.
that or sorry, general
General
practice
practice.
as
Yeah, like I said at the beginning, I didn't want to be a GP because I didn't quite enjoy it when I was at medical school because it just seemed a bit boring to me. When I was in hospital, it was very busy. You had the bleep, you saw there was more commotion going on. Everyone was working in a team. But then when I did my F2 job, my second year first job was in general practice in North Wales, in Llanfyfechan and Penmaen Mawr. That changed my mind. I suddenly realised that you are working in a team in general practice, albeit you're on your own in the room, but behind you, you've got your team of receptionists, admin staff, you've got other doctors in the practice you can always talk to. And ultimately, the most important thing is the interaction between you and the patient. So that discussion that anything could come through that door, whether it's gynae related, whether it's a baby, whether it's someone end of life, whether it's a musculoskeletal, could be a heart attack coming in. That's what fascinated me even more. That in the unpredictability of every day, which made me think, you know what, I'm really happy. I think this is something that I can do because I liked every single specialty I did. I didn't particularly say, oh, I really want to be a pediatrician or I really want to go into spines, or I just enjoyed everything. So it just made me think this is a specialty that can involve all specialties, and I can enjoy myself with being involved in everything.
so talk me through so where you are now, was that your first, or did you uh, were you in practice somewhere else prior to?
Yeah, so this job I'm in now is my third general practice job since
Okay.
qualifying. Yeah, I was qualified as a GP in 2018. I was training for 6 years because of part-time training and with kids and stuff. And yeah, so it's my third job. And yeah, I'm absolutely loving it.
And I mean, to me, it's the most amazing practice.
Yeah,
I won't mention the doctors' names, but they've been incredible to my brother who passed away in 2022, and to my mum who sadly passed away almost exactly a year ago. She had a second stroke, and then she passed in early August. But you know the bedside manner's always been amazing. They were always able to listen. There's a lot of criticism over general practice, but the phone calls from the receptionists, or from people checking on medication, or I mean, genuinely blown away by the quality. I mean, it's
yeah.
just incredible. So when you found it, what was the process of actually, was it a job advertised, or was it word of mouth, or how
So this is interesting. Yeah, this is an interesting one. So when I was applying for the job, because I was quite burnt out in my previous job and I needed to get away, because once you start feeling that pressure and not being valued, then you need to move on. And when I was looking for jobs, there were only 5 jobs in the whole area that were advertised. I mean, may have been some jobs that were internally advertised between people. People have got availability, but they won't advertise it because they've already got someone lined up. But this one was one of the 5 jobs. I just applied for it, and they invited me for interview. And it's actually my first ever proper interview because most of the other 2 jobs I got on a kind of "Oh, Zainab, we'd love to have you in our practice. Why don't you come and work for us?" And this was the first time that I'd been challenged in an interview. So very interesting, and they gave me the job. But one of the things, you're absolutely right about this practice, the reason why it works so well, when I compare it to other jobs, they are very patient orientated. They have meetings upon meetings about how they can improve the service, practice meetings, prescription meetings, significant event analysis meetings. They have clinical meetings. They're constantly on the ball. If anything does needs to be changed, they involve everybody in the decision. And reception have a voice, and we all have a voice.
How many patients are there in the practice? Because where it
Yeah.
is, it's actually quite interesting because the building is a shared practice building, isn't it? It's got it's a common reception, but actually two separate practices in that main area, and then there's
Yeah.
also something at the back, isn't there?
Yeah, I've never been to the back. The other day I was thinking I might just explore it.
That's
But
funny.
yeah, there's about 6.5 to 7,000 patients in this practice
Okay,
that I'm in now.
right.
Yeah.
And the other neighbouring practice, that's
Yeah.
about the same, is it?
Probably. I'm not sure actually. I've never looked into it.
That's so funny. It always amazes me that you walk in the entrance and what you go one way
Yeah.
or the other. And but
We bump into the doctors as well. We always bumping into the doctors and we're saying hi, hi, and but they're not part of our practice, and yeah.
so people who don't understand, a general practice is actually a private business, isn't it?
Yeah.
Would you just kind of talk through that
Yeah.
aspect and just how it works? What what the contract is and how
Yeah.
typically the practice gets remunerated
Okay.
and just how it works.
Yeah, so general practice, like you said, is an independent business. The NHS provides the funding for that practice. So, for example, the building costs, or they give you money based on how many patients you have. So each patient has a number, like maybe I think it's about £100 per patient per year. So it doesn't matter how often you use your practice, that's the number that that money the practice will get. Even if you don't go for years, they will still get money for you being registered there. So that's the kind of basic income that a general practice has. Following that, there's different contracts. So the GMS, which is the general medical contract, and then there's the PMS, which is more to do with additional services, enhanced services. So the basic contract is what the practice should be doing to maintain good quality care. So making sure the blood pressures, the diabetics are all looked after, the chronic diseases, and you get remunerated on if you meet the points. So there are certain quality points that need to be met. So are patients meeting their target for blood pressure? Are they meeting targets for cholesterol? And you get paid on that. As is a child being immunised, and you get paid per immunisation. So there's some basic
This is
things.
separate.
Well,
This is like a top up in addition to the £100 that you mentioned. Right.
exactly. Yeah, exactly. So that's additional, and then you get paid for how much you meet the targets that the NHS has wanted you to do, and then you've also got the additional enhanced services. So if you do contraception, if you do coils, if you do joint injections, these are the additional kind of services, just in a basic kind of nutshell, that then give the practice more money, and then when that money comes in, then the practice then pays the practice owners are the GP partners, so they're the ones that own the business. They get all the money, then they pay the staff and everybody else, and then what's left over is what they take. They split between themselves, and that's what they have.
And
Yeah,
typically they also have a salary that they take out
yeah,
alongside all the other costs and all the other
yeah.
salaries, and then essentially if they make a profit on the top, that's their dividend effectively.
Exactly,
Yeah.
yeah. So if a practice is doing really, really well, then you can be rewarded in many, in a lot of ways, from that extra money that comes in. But people say, that if we keep mothering them about their blood pressure, is it to do with money and stuff? in a way, it is also to do with the fact that a good blood pressure is important. You want to make sure that that patient isn't going to suffer from a heart attack or a stroke. So these points are not there just for the points of getting money or remuneration. It's about patient care and making sure that general practices are actively working to help patients have a better life.
I mean, from a public health perspective, we know that
Yeah,
lifestyle and lifestyle, choices and has a massive knock-on effect to the number of times people will have hospital visits and GP visits. So effectively, if you can prevent, which is the key, then
yeah,
you're not having to do the far more expensive curing, which therefore the goal of those targets is really to prevent wherever possible, get people both managing their weight, managing their lifestyle, managing their blood pressure, and by doing so, you reduce the essentially hospital visits are and GP visits are only the essential ones. That's the basic concept, right?
absolutely. Yeah,
And
yeah,
and going back to your time in your daily time, what's your
yeah.
day look like?
So it depends on like the type of day. So on a day when I'm not on call, so I'm doing a clinic in the morning, a clinic in the afternoon, I typically have 15 patients that I see in the morning and 15 in the afternoon. But the 15 may not be face to face. There might maybe a couple of phone calls in there. They're all 10-minute appointments. And so, yeah, I get through that clinic and then I have additional admin. So I may have to look at blood test results, sign off a few scripts. Also, look at the the letters that come in as well. So quite a few things on the side. So my lunch break may not be a lunch break. It is looking at and managing all of that stuff. The home visits are few and far between at the moment because we do have paramedics that can go out. But if there's a palliative care case or somebody who really needs to see a GP, then we will also do those visits.
Okay,
And then on call days are more challenging, and I've been doing a lot more of those recently. So essentially, I don't have a clinic. I may have a patient booked in, depending on the need, but all urgent stuff. So if there's urgent prescriptions, urgent queries, somebody needs to be seen, urgent like documents to be seen, patients need to be seen at home. It's a lot more kind of, and I'm supervising other colleagues, so all the trainees in the practice will come to me and debrief all their patients. If there are medical students, I see their patients. So it's a little bit more flexible, not time constrained, but it's more pressured in getting everything done. And I do all the e-consults as well that come in on my own call.
and the consult through the app or is it the website? I'm
Yeah.
not sure.
So it's an accurate. So I think if
Okay,
you go onto the website, you can submit an e-consult via the practice website. That comes through to a system on our side called Accurix, and we then go through all the ones from the day before. So if it's something urgent, we say to patients, ring up and speak to reception. But if it's something that can wait a day or two, and normally we check the ones from the day before and try and solve them that day if we can.
okay. So we just had a little break, but just getting back into the question of let's fix the NHS. So we've talked about the vision for this organisation, and when I say this organisation, I mean let's fix the NHS. My media vision,
Yeah.
and what I believe is the brain power and the motivation to fix the NHS is within the people at the coalface, whether that's the healthcare assistants, whether it's the GPs, whether it's the consultants. There's a great deal of knowledge. There's a great deal of passion, of expertise, of capability. But there's also frustration where the system is almost working at odds with the people within the system. And, I've seen in my mum's experience and other experiences, sometimes when amazing care and amazing support is given, but then it's a bit like 3 steps forward and 5 steps back, where there are things that undermine the great care that is offered and given, and I have massive thanks to most of the people within the NHS. There are one or two where they have been, in the past very rude to my mum. I remember one occasion, one nurse, my mum had a bowel resection in 2019, I think it was, and this lady was just so appalling. It was just remarkable. And I actually complained at the time, and the response from the head of the ward was, we just can't get the staff, so we know what she's like, and we have to live with her. And yeah, so I'm kind of curious as to, I'm guessing there is some sort of love-hate relationship in there, as you love it mostly, but there must be frustrations as well, or observations, whether those observations for leaders in the provision of general practice or in the NHS broadly, or with politicians. I'm just kind of curious as to, we know that the pressure on clinicians and on people within the system is massive.
Yeah.
And we also know a lot of people want to leave and do leave, whether it's to go to Australia or to go to the States or to go into some other career, or to become a YouTuber or a media star. We'll talk about your media career in a little while.
Yeah.
But yeah, so I'm just kind of curious as to where you stand on what's required to fix the system and what's wrong with the system.
So thank you so much, Steve, for the question. And I want to say firstly that this Fix the NHS company that you've started and you want to do so much good for the NHS is fantastic. We need more people like you. We need people to invest in this and really think long and hard. The NHS, we want to give patients continuity of care. And like you said, that's really important and that's what's expected for us to do. But my question is, how much continuity of care has the NHS had? Because if you think about the number of changes in government, the number of changes in the health secretary, and how much training have they had to understand the NHS in order to fix it? And fixing the NHS is like trying to fix a moving train. We have to keep the services running, and we can't stop services, but we're also trying to improve them. And that's also a very, very difficult thing to do. Like when you're running a practice, you still got the appointments running, you've got everything going, and suddenly changing an appointment system is not going to happen overnight. It's going to take gradual time, and also patients need to be used to what the changes are too. Patients will all be, oh yeah, I just ring up for an appointment. Oh no, but now they've changed it to e-consult. So it's getting the patients on side as well.
Zainab, how do these changes come on down from on high? What's the sort of process of some sort of policy change or a new technology, and what freedom do you have? For example, choosing a technology, choosing an appointment system. What how does that work?
So, from my understanding, we've had a new Docman company come in to look at our Docman and decide on the coding and things like that. So, how that happens is actually, as a salaried GP, I don't really get a choice in that. It's the partners of the practice who have researched it, and they will invest money into that from their dividends that they get at the end of the month or end of the year. So it's essentially having meetings in the practice, speaking to staff, preparing them, sending emails around like this is the change that's going to happen, and almost giving them the heads up that this is going to happen. If there's a change in our sort of recall of patients, or for example, a policy is changed in the practice that relates to patients, we usually send a text message before that happens. So we normally message patients or ring them to let them know that this is the change that's going to occur, or we put it on the Facebook or we put it on the website. So it's about preparing the people. The change will happen at a particular date, but it's then preparing everybody.
But if something's happening from government, if it's coming,
Right, yeah. So then you'd have meetings within the practice, discuss them, but those changes may well involve patients in the sense that, they're changing the QIF guidelines, or QAF, what kind of quality improvement frameworks are now going to be in place this year, or what kind of quality improvement activities need to be done. So we will try and do what we can in practice, and as individual practices do individual things. So like I said, meetings and things, but it's not it doesn't take long. It just means we just have to inform people. It's about communication at the end of the day.
But this all
And
takes time, doesn't it? And
it
but,
really does, yeah.
but go back to the continuity of care and the NHS having that. So it's interesting. I mean, Wes Streeting talks about the fact that there were 5 health and care ministers before him within the last government in and that change, obviously, it can be unsettling. The reforms of 2012, where GPs were then essentially responsible for the commissioning of services, and it created a lot of distress in a way, because previously you had professionals doing that work, and then all of a sudden GPs are taken out of practice and they have to essentially be involved in the managerial activity at a higher level than previously. So it's interesting to know what is going to come with the new NHS reforms. Are you hopeful?
Yeah, I am hopeful. I do want to say one thing though, that general practice is, I don't know if you've heard about the job crisis amongst GPs at the moment. A lot of GPs are not able to get into a job. And I don't know whether this is a result of the fact that they brought in these additional reimbursement roles. For example, physician associates, ANPs, advanced nurse practitioners and paramedics into the equation. But there are many GPs now that are leaving the country or going into other jobs. And I'm not sure if this NHS reform plan has anything in there that will help those GPs go into a job. I know a lot of colleagues that are not in a job. It's quite scary, actually.
I mean, that
Yeah.
amazes me when in some places it's very difficult to get appointments where
Yeah.
there's pressure on resources. That training is essentially going to waste. So when you look at the long-term cost to the country it's cheaper to essentially employ those personnel. We also have to look at who's retiring, and if we're literally letting people walk into other unrelated roles or other countries, having spent, I'm not sure what the cost is of training a general practitioner or a doctor on any level, but I would think it's not cheap.
About
And I
$250,000.
right, but that's
Yeah.
funded by the
From,
doctor themselves.
yeah. No. So essentially, when you're a medical student, you're paying student loan and things like that. But there is a cost to the government for training training doctors. But when you're a GP trainee, it does cost money then as well. To train a GP. Now, one of the things that I will say is that they have increased the number of training posts in general practice, but they haven't accounted for the fact that there are no posts for them to go into when they qualify. So these GPs are about 100 in this area at the moment, and then I mentioned there were only 5 jobs in the whole of Stoke when I was applying that were advertised, and that's very unnerving, because in my opinion, when I was applying for general practice, I thought, oh, I'm guaranteed a job, I'm guaranteed partnership. But you know what's going on now? Even practices who are having retirements happen with their partners are not recruiting more partners. That's another thing that seems to be happening too. So, oh, sorry, my hand went up. So
So
essentially, yeah.
so how does that work within the General Medical Council or the appropriate governing bodies, the Royal College of General Practitioners?
Yeah.
Are there strict rules of the ratio of patients to partners, for example, in a practice,
Yeah.
or clearly if you and there are companies that are acquiring and rolling up practices, aren't there? So I know that the practice that in London I previously was registered under, I think they had
Yeah.
30,000 patients,
Oh, wow.
and is a part of a group that have other practices as well. And
Like a super practice.
yeah, a super practice. So, you know, when you look at the transparency of the financials, is there anywhere where one can look and find out, are they, it's like the Charity Commission. The Charity Commission has very strict regulations on how much directors get paid and how much
Yeah.
trustees get paid, and how the ratio of funds raised to marketing expenditure and things like that, and program related expenditure.
Yeah.
And there's transparency. You can go onto the website and take a look. So, does something similar exist for a general practice?
So yeah, you can go onto certain websites for the GP, and they do sometimes put on the average salary of a GP this year was, they won't give specifics. They won't give like the individual GP's earnings, but they'll give an average of what a GP has earned that year in that practice. But what worries me is that obviously if a GP, like those GPs that were partners before, the salaried GP position didn't come into play until 2004 when I started medical school. That's the first time the salaried GP role was created, because of the whole kind of, some GPs didn't want the business side of things. They just wanted to do their, clinics and go home. And then they would be employed by that practice. But then, in a way, now if a salaried GP wants to become a partner, it's a battle, because in the not olden days, a few years ago, it wasn't even about like how experienced you were. Some trainees would be finishing GP, go straight into partnership, and people would give them the opportunities. Now, unless the practice you work at wants you to be a partner or is happy for you to be a partner, that no one even approaches that topic. And it does make me a little bit unsettled, because I've now been a GP for 6 years, and I would love to be a partner because I've done so much clinical work. I'd like to explore how much more I can help patients and help the NHS in my area. But unless that partnership wants you or has the capacity for you, they're not going to offer you that role. And I never thought that was a thing until I got to this position.
Yeah, it's interesting how those. How many doctors are there at any one time at this particular practice?
So in my, do you mean like in the? I mean, in my practice,
Yeah,
there's maybe two main GP, like the two main GPs that
yeah,
permanently work there,
yeah.
and then there'll be trainees
Who
and
I,
other
I
people.
think are
But
both fantastic, by the way. I think they're amazing.
yeah, oh, thank you so much. But in another practice that I know of, there are over 20,000 patients with just two partners, and they and then you think, wait a minute, a partner should have approximately maybe 3,000 GPs maximum between them. So it just makes you think, how are they managing that?
But
Because
sorry, but that's a partner. But if you take a salaried GPs, nurse practitioners,
yes,
and physician associates. So
yes,
if you say that's all clinicians, of
yes,
admittedly physician associates can't prescribe, and there's certain other things that they can't do without essentially supervised support. But
yeah.
essentially, how many people take that 20,000 patient practice? How many
Mm,
clinicians would there be, even though there's two partners? In your opinion,
right. So, I mean, do you think, in my opinion, what should be, or in my opinion, what I've seen, what I've
I,
seen?
I would say what would be typical.
Okay, on a typical day, there probably would be one of the partners would be in, then it would be a couple of salarieds, maybe a couple of physician associates, one ANP, and maybe a couple of trainee doctors as well. but I get,
So
this is what I saw
that's
then.
about 8 people, isn't it?
Yeah, 8 people.
Right, plus all the
But it's
admin
still,
and nurses
yeah,
and others.
yeah, and a healthcare assistants as well.
Right,
Yeah,
right. So eight to 10,
yeah.
and but that's for a 20,000 practice. So are you suggesting that the numbers need to be weighted in favour of more senior people, i.e., partners for that practice?
Absolutely. Because partners are essentially, they're the mind of the practice. If you've, like in the practice I'm in now, I look at how much they do and how much they try and change practice for the better, and the meetings that they have with just only 7,000 patients approximately, and then how they never actually had any meetings at all. There was no improvement of services. It was just like, carry on, let's just carry on, and almost like, let's just keep going, but no changes in services, no feedback, and it just felt like it was disjointed. And I think the number of patients, you need to reflect that in the number of doctors you have, 100%, because it puts a lot of toll on the staff. It puts a lot of toll on the admin staff, the reception staff, the number of phone calls coming in. 20,000. That's a lot of patients for one practice and two partners. 100%.
I mean, it would be interesting to look at the, forensically, to look at the numbers of
Yeah,
successful practices, high satisfaction, high
yeah,
ratings versus the opposite. And the vision for Let's Fix the NHS isn't about me alone,
yeah,
hosting discussions and interviews. It's about having a lot of people. The vision is really to have business and corporate sponsorship paying for quite significant content production
yeah,
capability, and that would mean we will be able to do investigative journalism type activity where we're
yeah,
looking, in detail at what makes a great practice, where appointments are available, and where there's feedback and follow up and text messages. And I don't think it's universal that people get a text message, for mentioning their appointment or reminding them to take their blood pressure. Now, maybe it
yeah.
is, maybe it's all the way through, but I don't think so, from what I understand.
No,
And
I mean, this practice I'm working in now, I've learned all these things here. I've not, and I feel good about it, because I feel patients. That's what we're there for. We're there for the patients, and being in contact with them through the e-consults or ringing them, and it's just a breath of fresh air.
I mean, it's
But my
interesting.
views, sorry,
Well, I was just going to say,
sorry.
if you did you watch the interview with Sir David Haslam? Did you see that
I watched it. I've
discussion?
watched it. I watched a little bit of it. I couldn't
Right.
watch all of it, but it was very interesting.
Yeah, it's a bit long, but hopefully
Yeah,
you can get back and see some of it, or the bits you
yeah,
missed. But one of the things that we talked about is Rudy Giuliani, the former mayor of New York and Trump acolyte. But quite a number of years ago, he wrote a book on leadership, and it was really fascinating. And it's interesting, when I mentioned it, Sir David said, I've got that on the shelf, and it's a great book. And what he did was, or where he's got the direction he's gone in was tragic, I think the term he used. But in that book, we talk about something called CompStat, which was
yeah,
or he talked about something called CompStat, and I remembered it. And essentially what they did is they got the leaders of the different boroughs for the police service or the fire. I'm not sure whether it was health as well, but they got them essentially together on a monthly basis to compare their statistics
yeah,
that had been compiled. I think that's where the term came from.
yeah,
And so murder rates and arrests and different things. But all of those essentially heads of police chiefs for the different boroughs, in that monthly meeting, they had to defend their numbers or support them and explain how they'd succeeded or what went wrong, and that meant they could learn from each other. And
yeah,
David said that that reminded him of what he did 30 or 40 years ago, where practices in his general practice, other practices, and I think he led it, got together to compare notes and to improve their capability, and also learn from the mistakes of
Yeah.
others. And I just thought that was fascinating, because that system really should be universal. It should be, the great things that Mount Road are doing should be shared with other practices on a regular basis, as well as the great things others are doing and the problems that they've had. I think we should be comparing our stats in the same way. What do you think about that?
Yeah, yeah, I agree. I mean, we do have PCN meetings, and the primary care networks, which is a group of practices in
Right.
the same area, sort of get together and they have monthly meetings, and they talk about the services that they want to use, and they have PCN staff, so they share the pharmacists, they share various other roles like dietitians, social prescribers, first contact physio. So there is their camaraderie between practices. I do agree with that. But one of the things that I think is so important is we need more practices, Steve. We do. Patients are struggling to get appointments in the ones that are existing already, and there are GPs who don't have a job. So one of the parts of me feeling that NHS needs fixing in is to make more practices. Now, I actually approached the local medical committee chair and asked him, how do I go about opening up my own practice? Because I've got a few friends and we want to get together. We have the same vision. We get along. We could be partners in this practice. But apparently it's not that simple anymore. So it's not as easy to open up a new practice. There are practices that are expanding. There are certain practices in my area who have bought out a building, and they're going to try and make that into a practice and maybe employ more partners. But I'm not sure how far down the line that's gone. So,
Yeah,
and if you want
interesting,
to
isn't
bid
it?
on a practice, yeah,
So maybe that's something for another discussion, to focus on, that very question: how can new GP practices be formed in this country? And
yeah.
and are there many patients who just can't get a GP? What's the situation?
Yeah. It's really difficult. I see as many patients as I can, and when I'm on my own call, the reception staff, if there are no appointments available, and someone rings up with a query or they're not sure, they'll send me a task, and I tend to deal with that patient. So if people say they can't get appointments, sometimes I don't know what's happening, and if they are ringing up, they're staying on the phone long enough. I don't know. We have quite good access in our
No,
practice.
no, that's what I'm saying. I mean, your
Yeah,
practice is great. I'm saying it elsewhere
yeah,
in the country.
yeah,
The it is. I mean, and don't we won't go for around dentistry, but in
yeah.
terms of GPs, there
Yeah,
is a shortage of GPs. Not everyone has a GP in some
yeah.
areas.
There should be. They should all have a name GP. To be fair, they're registered with the practice or we registered with a GP. But I do know people who struggle to get an appointment in other areas. So they'll be like, oh, yeah, I haven't got an appointment for 2 weeks. They've given me a face to face for 2 weeks. Or they have to keep ringing up in the
Right.
morning. And sometimes by the time they get to their turn on the phone, the appointments are all gone and they have to re-ring again the following day. I think for me, the biggest change that has happened, although it was a bugbear of mine to even accept in the first place, was e-consults. Like literally, if you have a query, if you send an e-consult in, I will see it. Because I have to go through the ones from the previous day. So you will get an answer. I text them back on that day or the day after and let them know what I'm doing so that they're up to date with everything. So e-consults are good because if it's not a really urgent thing that you need to see the GP about, and I can always book an appointment with them as well and say, oh, do you want to come in tomorrow for, I can override an appointment for the following day if they need it, or on the same day.
Well, maybe that's what we could do is, if you're up for it, we can do a
Yeah.
something you can share on your social media.
Okay.
Maybe we could do a discussion, a two-way discussion, that we can both share on our own platforms
Yeah.
about just e-consultations. What are they?
Yeah.
And because I do think there was a lot of people who clearly don't have access, older people, particularly if they don't have family, and that does, in a way, cut them out of the system. And even being on the phone, waiting for your 30th in the queue isn't ideal for a lot of people. And I've never quite understood how when like a millisecond past 8 a.m. You can be 30th or 20th in the queue. That always
insane.
Fascinates me how that phone system works. I would really love to know what's the trick. But still, the fact that there's that sort of pressure, maybe there's a better system. And I know at your practice, the best way is to arrive at 10 to 8 in the morning and have a face-to-face. I mean, that's a little secret there, but not everywhere has that capability. So, but I think yours is one of the best. But it would be interesting to explore this, how it works at different practices around the country, and see what works and what doesn't.
I think e-consult, when it first started, I had that same reservation because the previous practice I was in, there were a lot of people who didn't speak English as a first language, and I thought, how are they going to be able to answer? And yes, a lot of elderly population won't be able to use it, but in our practice, as you know, majority of the patients have phones. If a patient doesn't have a phone, then we tend to ask reception staff to fill an e-consult on their behalf, or if it's an urgent thing, they send a task and we can then ring the patient back on their landline or contact them a different way.
Have you heard of something called Live Well? It's in Manchester. They're sort of pushing it, and it's really about bringing health into the community. So that could be through church environments or social settings, social clubs, and things like that. And it's really, it includes things like social housing and making sure all aspects of people's lives they're living well. And there was Andy Burnham, the Mayor of Manchester, was at an event which talking about it, as well as some of the heads of Manchester City Council. So it's really about sort of public health brought local. I think is probably the best way, and it's something that I want to dig in a little bit deeper and maybe interview someone about it, because as I understand it, it's about pushing as much responsibility, whether it's for taking blood pressure and understanding people's numbers, onto local organisations and local personnel to essentially support that process that the GPs are delivering, and going back to fixing the NHS, a lot of the pressure on the system is people who are going into A&E because they can't get an appointment, and with their general practitioner, and when you think about that, it really is crazy that people will go and wait sometimes for a long time at A&E, taking up time, taking up space, and often it's for things that are I won't say trivial, but let's just say routine. Just to kind of wrap up, because your time has been amazing. This has been a really fascinating discussion, and there's lots more to talk about, which we can talk about maybe another time. But just final thoughts from yourself on fixing the NHS, i.e., what levers could be pulled. We know we want to explore how new general practice can be created. We digital services around the country, maybe AI. Any thoughts on AI? And then to wrap up, talk about family, your kids, and how a busy mum fits in this incredibly busy life. Serving people.
I mean, AI is interesting. I find it a bit scary. I think when you watch real like movies like Terminator, and you think, oh my goodness, could that really be real? That then suddenly you get cyber machines like taking over like operations and then taking over the world. But yeah, I think AI is interesting, especially Heidi, which is the one where you do a consultation and then it sort of summarizes your consultation. But the danger is, I mean,
Do you
how
use that
accurate.
yet?
No, we haven't used it, and I think we're refraining from using it at the moment. It is amazing that something like artificial intelligence can dissect a consultation and put all the main points in, but I'm always worried that it doesn't. Sometimes there are things in the consultation that you need to add on as well, a human factor, for example, how they're feeling, what they're looking like, are they crying, or so for me, it's also a legal document as well. So sometimes there's certain things that AI may not pick up. So we still need to add in our side. That's my worry, that we're going to rely too much on that.
There's privacy and data protection,
Mm.
considerations that
Yeah,
if an AI is recording, to then be able to summarize what happens with that data. Is it held securely, and is it
mm.
only accessible to those that it should be accessible to? So
Yeah,
that's an issue. And then, but the flip side is, how often is a GP super tired, not able to get the notes down accurately, and how
yeah,
and as much as they need to, how often do they miss other things? So
yeah,
it's all, I see it more, rather than artificial, I see it very much about augmented intelligence. But as you say,
yeah.
the responsibility is still there.
Mm.
And my experience with ChatGPT is it's made me a lot more productive, because
Right.
and it picks up things that I've missed, because I write a lot, but over the years sometimes I won't say you become lazy, but you miss things, and it's really
Yeah.
quite amazing to, um,
Mhm.
if you do your own consultation and write your own notes, and then test with, I think you said it's Heidi, but maybe with
Yeah.
the permission of your patients and your partners, test the alternative, or test
Mm.
the AI, and then compare them. It would be very interesting
Yeah.
to see, a couple of dozen consults, and how they compare. And because again, if we can use that just to give 10% back, that's 10% more
Yeah.
patients that could be seen. When you have the knock-on effects of this used right the way through, the health system broadly, including non-NHS. I mean, for me, fixing the NHS is as much about taking the burden off the NHS. So, the serious stuff, the important stuff can be done without the burden of things that frankly are routine, and are taking up time. So if we can strip some of that extra time that is wasted, out,
Yeah.
and put productive time back in using these tools, I think it's incredible. But
Yeah. I mean, like I said, I'm one of those people that sometimes finds it hard to adapt to new technology, and with e-consults at the beginning, I was a bit reluctant, but now I think it was the best invention. I'm thinking this is awesome. Like fit notes can be requested through an e-consult. They don't need to send a task, which adds more pressure. But with Heidi and with this artificial intelligence that is being incorporated in some practices, you're absolutely right. It does save time, because I type as I go along in practice sometimes, and think, am I taking myself away from that interaction with the patient? These things do make a difference. So, yeah, it would be interesting. I'd be open to using it and seeing if it does change, if it is similar to what I would write, and does it include all the red flags, which I'm really passionate about. Then, yeah, it would be something. I mean, I would, yeah, use it. But it's just, yeah, like you said, data protection, and how secure is that data? How confidential would it be? If is AI able to? Is that able to do that, keep it confidential?
maybe that's
I don't
something we
use
could,
ChatGPT about this.
inquire with your partners, but also with
Yeah,
the suppliers, and slowly take a look at it, because I think
yeah,
I just know in my life the last, let's call it 6 months, has been really transformed as a result of
yeah,
what I don't use it for everything, and I'm super careful to double check and to prompt effectively. But I'm amazed. Family. So just to kind of wrap up, and I'm super grateful for your time today. And I recognise you've probably got to get back to family, but you've got 3 children.
Yeah. By the way, I just want to say thank you for your time. Hopefully, it's been useful. I hope that I've helped in this discussion, and that was the aim, anyways. But yeah, I guess I'm not representing all GPs. It's my own opinion, and if there's anything that I've said that other people disagree with, then that's fine. We're all entitled to our own opinions. But yeah, with family, I've got 3 kids, 11, 8, and 4 at the moment. Yeah,
And
so busy household.
a busy household. So what are they?
Yeah.
So what do they think of Mum and her role as a GP? Are they old enough to understand that you're doing good things for people? I mean, how do they understand it?
Yeah, they do know I'm doing good for others. I think they're only little, isn't it? So they find it hard that sometimes I work, quite long hours, and they'll be picked up and dropped off by nursery, not by me, and that can be quite difficult too. But we spend a lot, when they're home, we spend a lot of time together. We bond and we talk about lots of different things. But they love it. They love the fact that both of us are medics. We have funny and interesting conversations with them. And yeah, and my oldest, I don't know what he wants to do. He's more of an artist. But my daughter, I think she wants to be an author. And the little one, I think he's just a stuntsman. So I'll just leave him to it.
Oh, that's funny. And your husband, you obviously been, is he a surgeon? Did you say cardiothoracic? Is that
Yes. Yeah, so
so?
he's a registrar at the hospital. Yeah.
And how do you talk about work at home? Is it, or do you try and keep things very separate, or how does that work?
It depends on the kind of day I've had. If I've had a hard day and I've had a difficult case, then sometimes I want to open up to him about it, and he will do the same. But the majority of the time, we're so busy with the kids. When the kids are at home, we're really just talking about what we're going to have to eat and what we're going to feed the kids, and let's put them to bed. Or it's more about that when we're at home, and what TV show we're going to watch next. So we try and make it not about work, but it is hard. Sometimes I have to do work from home. So if I'm logging in, then he will, he supports that, and he'll sit there and try and help me if he can as well to finish off the jobs.
Oh, that's very nice. And what about you? Do you help him as well?
His is a little bit more tricky because his patients are still in hospital, so he
Yeah.
can go back and see them. So for me, it's my patients are not in the surgery at that moment. But no, I don't really help him. To be fair, he does his own thing.
And just to finish the future, what where would you be in 10 years' time if you had your way? What's your vision?
So in 10 years, I will be 50. So I'm thinking by then, I hope that I will have been a partner for a few years and be able to contribute more to the NHS. I think in 50, I might want to consider start thinking about retirement, in the sense that I do want to go into the police constabulary and work with there's a stalkers unit in Cheshire, and they have no idea what's coming. They have no idea that I've got interest in them, but they will hear about it. It depends. I mean, I may want to stay in the NHS longer. I mean, the retirement age has gone up, isn't it, for all of us? But I do want to, before I hit my 60s, and I want to be able to do something different with my life. Maybe do a bit of my artwork, or continue my social media. I've got no idea what's going to happen with my TikTok.
We didn't cover that. That's what we need to cover just briefly. So
Oh, right,
so
okay.
just
Yeah.
yeah. I mean, I have really enjoyed seeing some of your posts on. There's a few on YouTube, but Instagram. I've not got into the TikTok, but I will do. But yeah, just how's that gone, and what response have you
Yeah.
had, and just explain it for people who
Yeah.
and where people can find you.
So TikTok is just a platform which started off a few years ago, basically with dancing. It was like short videos for dancing and things, and then people started to post on other things as well with relation to the news, like things that are going on in the world, but also about healthcare. When I joined TikTok, it wasn't. I didn't even think I was going to make videos on health. I just thought it's a social media platform. I'm just going to post about what I did. I'm doing my STEM ambassador work, or I've been to a conference. And then I don't know what happened. I just decided to do a video on bowel cancer screening once. And suddenly it was almost like, oh, that was a really good video, very informative. Can you do this and can you do that? And then somebody said, could you do it in Urdu? And I speak Urdu, Punjabi, Hindi, but not in medicine. So that did take a while, but then I decided to do Urdu videos. That's what actually rose my account numbers. I think from one video I got 2,000 followers just by speaking Urdu, and I thought, wow, reached a different population and audience, and helping those people. So yeah, that's why I decided to continue doing it. And sometimes I'll put the odd video of what my feelings are, but other than that, I just do medical content, like on certain conditions like scoliosis, brain tumors, high blood pressure, different cancers. So, yeah.
So I'll put your ats on the
Oh
screen.
yeah,
But
yeah,
just tell people where they can find you, what your
yeah.
Instagram
So
and
my Instagram handle is at Dr Zainab GP, all one word. My TikTok is the Doctor 2010 because I qualified in 2010. आज मैं आपसे ब्लड प्रेशर के बारे में बात करना चाहती हूँ। ये जो ब्लड प्रेशर की बीमारी है, ये एक खामोश बीमारी है, लेकिन जो वैसे पाकिस्तानी है, इंडियन है, बांग्लादेशी हैं, इन पॉपुलेशन में and yeah, those are the two main platforms that I use. I do have a YouTube account, but it's just Dr Zainab Hussain, which is my name, and that's it really. And they
Facebook.
can
You're on
contact
Facebook
me.
as well.
I'm on Facebook too. I think you can follow me on. I don't know why, but you can't add me as a friend on Facebook for some reason. But I'm on Facebook and I do sometimes post on there. But that's more of a personal
Okay.
account rather than a kind of a public account kind of thing.
So just Instagram and TikTok and a bit of YouTube.
Yeah.
So amazing. Hopefully we can post some shorts from this to that if you wish. You'll be very welcome.
Yeah, that's fine.
And we'll talk again. But I really appreciate this. It's been amazing, and I'm very grateful. So please watch the future of Let's Fix the NHS. The goal really is to ultimately get this properly funded, properly sponsored, have quite a team, and to do some very exciting live events where we have panel discussions, audiences, and focus on sometimes nationally and sometimes regionally. So it would be great if you participate in that when we do it. It might be a little while down the road, but I think you've got so much to give, and I think your next 10 years, and you've already given so much. So it would be nice to think you have a part in a practice. You're giving your leadership capability, and then when the next generation come along, then wouldn't it be amazing to see you there with a truncheon and special constable or whatever. But Zainab, thank you very, very much. I really do appreciate it, and we'll catch up soon.
Definitely look after yourself, and and we'll catch up soon.